Hello and welcome to Differential Discussions. I'm Melissa,
And I'm Dave.
and today we're looking at a slide of a dimorphic population.
Really cool. It's striking looking at the this picture. So
Right.
dimorphic. What do you
What is
mean
that?
strike? It just caught my attention immediately. So
What's
um
striking about it, though?
yeah, I think the literally the two populations of cells that I can see here. So both in color and in the poikilocytosis, the shapes, I see these two distinct populations. And I hadn't seen this slide at all, in truth, before, and like what 5 minutes ago, we just peeked at it, and Melissa was wanting to do this video on a dimorphic population, and I suppose it caught me off guard how in my face it was. Because I know I've seen dimorphic populations in the data set, and then on the slide, it's maybe not quite as like in your face as
So,
this.
so how do you see it in the data set? What do you see?
Very good. So you'll see a crazy high RDW or no RDW at all, depending on the instrumentation, and how different the populations are. But the most visually kind of attention grabbing would be the histogram on the red cells. They should show two, maybe not perfect Gaussian bell curves, but two distinct bell curves representing those two different
Well,
populations.
let's draw it. So if we're looking at a graph,
Yep.
normally you see something ideally like this. Well,
Yes.
not quite like that, a little bit further down, but something like that.
Yeah. Mm-hmm.
And then
Yep.
when you're looking at something with a dimorphic population, it means you see two distinct populations. So you have two peaks. Sometimes it's called a cowboy hat or something similar where you see the two peaks. So you're going to see something like this, where you have this and then this.
Very good. I'm
And
glad you drew it like that, right? Because rarely is it like,
yeah,
yeah.
well, because usually you either have a normocytic population with a micro or a normo with a macro. So
Mhm.
your peaks are not usually like this far apart.
Right.
Occasionally, usually in MDS, you can see a micro and a macro population, and that's when you would have the two peaks pretty far apart from one another. But for the most part, you're going to find them relatively close to one another.
Yep. Yeah. So you see something like this. When I see something like this, I think the first thing I think of is transfusion.
Yeah.
Um,
Yeah.
but yeah. But yeah, certain pathologies can have different clonal populations, and they can produce this spectrum of red cells. Um, so yeah, and so there's definitely a size differentiation here. I can see those two sizes, but I can also see the hemoglobin concentration of these two populations is vastly different as well. So very, very fascinating. And at a glance, um, the one population looks macrocytic, like they literally look large. So that's what I have in my head. That's my feeling. Um,
Yeah,
but
the population that has a greater coloration of the hemoglobin, it looks macrocytic.
they look huge.
I mean, we're on 40, so we're
Yep.
still kind of, just kind of gauging what we're looking at. But yeah, just my first impression is they're macrocytic.
Yep, absolutely. So we'll have to see, you know, how that pans out. But yeah, maybe we can go down and take a closer look at some of the cells. So yep, perfect. So in other videos, we may have talked about the lymphocyte, specifically the resting lymphocyte and its utility to the morphologist. The resting lymphocyte ends up being an excellent visual anchor for gauging roughly the size of the erythrocytes. So now I can see with this lymphocyte in the field that large population is probably a quite normally sized population, and that we actually have a super microcytic population that's giving us this visual, I don't want to say illusion, but we misperceive the reality here. Um, Really cool.
Yeah,
So
and we'll see more when we go down to 100.
yes, yes. So yeah, maybe as good a time as any. Spin down to oil. Perfect. Really cool. So yeah, now that we're close up, we can see those darker, richer, more higher concentration hemoglobin cells are the size of the nucleus roughly. So those are our normocytic cells, and the others would represent our micro hypopopulation. There does appear to be perhaps some artifacts. I wonder if these are real. Let me see. I'll bring
The
it up.
echinocytes.
Yeah, yeah. So like I'm looking at some of these like kind of, are these really targets or whatever. So as we kind of look around a bit, we might see if some of those things stay consistent. But in my hypochromic population, I see a lot of ovalocytosis. I'm seeing a bit of echinocytes. So this is interesting, right?
Yeah,
That
I'm wondering about the echinocytes because you
Mhm.
can see like some of the normocytic cells also are echinocytes. So I'm wondering if it's the population, and it's not just the abnormal population here. So it could be artifact. It could be that this patient's really uremic, and so the new cells that were transfused in are also becoming echinocytic. We just don't know.
Yeah, so that was I'm glad you said that. That was exactly my thought process. Is I'm intrigued that there's echinocytes in both populations. So, like Melissa said, so echinocytes are a tricky thing. You can do everything right at the bench, and the slide still produces sections that have echinocytes. Okay. Generally speaking, though, it'll be localized. So if you look around in other areas and you see that the echinocyte populations kind of go away, it's likely artifact. Don't report it, right? But otherwise, it is a kind of an important thing, is maybe to this patient's pathology. But yeah, I guess we'll have to see as we look around a little bit more.
The
But
other thing that I want to point out is this cell here. It looks like a normal cell too, so I'm wondering if it's an artifact.
mm,
But it looks almost like there's like a Heinz body or something. Yeah, exactly, a bite cell right there.
yep.
But it's one of the normal cells, so
Right. Yeah. So there could be just some kind of weird things going
yeah.
on here, but excellent. So I'm glad you brought that up. So a bite cell, it looks like a bite has been taken out of it. In reality, there's oxidative damage to the hemoglobin molecules, and they will kind of stick to the cytoplasm and they won't stain, right? So visually, it looks like a bite on right stain. If we were to do a methylene blue preparation on this blood, we would see a dark blue Heinz body attached to that membrane to correlate there. But pretty cool. You see that in G6PD, especially after some kind of an oxidative insult, medication, something to that effect.
You want me to move around now?
Yeah, let's take a trip. See what else we see. So seeing echinocytes still. Yeah, I wouldn't be surprised if this was maybe some kind of uremia kind of issue. Although echinocytes and liver disease too, right? I'm trying to dig into my memory here. So there's a couple of different pathologies, but that would explain something that's a systemic problem where the environment the red cells are in are causing the issue would make a lot of sense in this context. It doesn't explain the hypochromia though.
Well, with uremia, sometimes patients have a concurrent iron deficiency or something. So,
And uremia, so I'm thinking kidney disease, anemia of chronic kidney disease, right?
well, we actually have a video on uremia. So if people are more interested in learning more about uremia, we can link to that also.
That's probably a fair point, rather than reinventing the wheel here. But what a neat slide though so far. Um, see some like teardropping kind of stuff as well.
Yeah, there's a fair amount of teardrops. I don't know yet that I'd call it
Yeah, right, right. That's fair.
pathology, but there are a number of teardrops throughout all the fields consistently.
Yep.
But yeah, again, just kind of showcasing that you have your normal, probably transfused population along with your hypochromic, microcytic, I almost said microchromic, microcytic population.
Still true, probably.
And it does look like there's some kind of hemolytic something happening with this too, because there are a number of cells that are reminiscent of schistocytes in here.
Mhm.
So which would also fit with uremia.
Yep, true. Yep. Yeah. So yeah, we've seen a decent amount of fields now, and I'm gonna go out on a limb and say that the data morphology is there, definitely.
Well, let's go a little bit thicker.
Sure. So we'll go to a very, very different area, and there it is. So it's still persisting.
Yep, it's still there. So we know that the echinocytosis is true.
Yep. So a really important finding. It's I think it's important that it's called. It might be something that gets overcalled, and like that can be a little difficult, but undercalling could be problematic as well. I would hope that the general metabolic testing would show the things the clinician really needs to see too, but this would be a great supporting evidence for diagnosis.
Yeah. And so I think just looking at the other morphology, maybe schistocytes,
Yep.
definitely microcytosis, hypochromia,
Definitely.
if the institution calls them.
Right.
Because the other thing to keep in mind when the RDW is this high is the MCV is not reliable.
Yep. Excellent point. So the MCV is an average of all cells. And you can imagine that if your data set is, I think it's fair to say randomly distributed, right? Because these are cells from a donor and then cells from the patient, that MCV is not going to be representative. Remember our cowboy hat? That MCV represents that spot in between in the middle here, right? And while mathematically true, is certainly not actually descriptive in a way that's meaningful to the
So
team.
for this case, we can say that like maybe this population here is our microcytic population. So maybe this is an MCV of like 60.
Yep. Yep. And then compared to maybe 90, right,
Yeah.
on our transfused population. Yeah.
So that we can see here that you have two distinct populations and what your MCV is, right? It's mean. The first word is mean. So your average. So what your MCV is going to be is right there.
And this actually brings up an interesting topic too, because that MCV is going to get reported, right? I mean, most institutions that I've interacted with, there's nothing to stop anything like this from going out. I think a lot of analyzers will give a not measured at this point on our RDW, but yeah, that MCV is going out, and
Yeah. And
yeah,
you know, we might put a comment on the RDW saying that there's a dimorphic population, but it comes back to interpreting the CBC. How many physicians understand that if your RDW is that elevated, your MCV is not reliable?
yeah.
And you know, it just comes down to how much training do they have in the CBC, which I don't know that a lot of them have a lot of that training. So it really is an important thing to know though about the MCV.
And this is where theory empowers you at the bench. So I know that there's probably a lot of techs that, or maybe even students, like, when am I going to use this stuff? And you get to choose when you use this stuff. And it certainly is applicable at the bench and can help the patient outcomes. So I encourage people to think about these things. And this is how processes kind of get changed, you know? I think a lab should discuss whether or not an MCV should be released in a situation like this. But you know, that's for administrators. But I didn't expect to have this deep of a conversation about this, about this slide in truth, but pretty cool.
Yeah.
Good
And
exercise.
I think that's really all there is to this video. So thanks for watching.
Yeah, thanks for your time.
Please like, subscribe, and hit the bell if you'd like notifications whenever we post a new video. And feel free to reach out to us on social media or via email with comments or suggestions about future content. Thanks.